everybody. This is Dr. Alice Lee. Welcome to iCubed episode 36. Yes, 3 years of this already. 36. So, folks, when I started this endeavor 3 years ago, I did it because I felt compelled to pass along what I had learned all these years of emergency medicine practice. And I never, ever would have thought that I would have a guest like the one I have today. Now, if there were ever a celebrity educator, my guest today totally fits the bill. He has a long list of accomplishments I cannot possibly read at all today. But let me just give you a few. I don't think there's anyone in today's world practicing emergency medicine that's never heard of Dr. Gregory Henry. So he was a past president of ACEP. He was a department chair for 21 years at Oakwood Hospital, Ypsilanti, Michigan. He has done innumerable lectures, many of which I have been able to attend, many conferences. And now he is the clinical professor at the University of Michigan Medical School at Ann Arbor, Michigan. And I am absolutely delighted and honored that Dr. Gregory Henry is my guest on iCubed today. So, Dr. Henry, thank you so much for agreeing to do this after I accosted you at ACEP this year.
Well, listen, Alice, I'm very happy that you've asked me. I feel honored. And so anything I can do to help you teach, I'm happy to do. So just fire away and do with it what you will.
Oh, wonderful. I do want you to help me teach, because this was a very complicated case, I think more than your typical. So let's just dive into this case, Greg. This is a gentleman, 66-year-old, that has a history of diabetes, hypertension, fibrillation, and he came to the emergency department with his wife and family, actually, because he said he was having vision problems, which started yesterday when he woke up from a nap about roughly 22 hours ago.
Right.
He said he feels fine, actually, except for not seeing well as before. So wife says, well, he was walking into doors and he had trouble seeing the food on his plate.
Teaching point.
Okay.
Whatever anyone says, I have a visual problem in the emergency department. You've got to decide where along the visual axis that problem lies.
Right.
After all, do they have something in front of their eye? Do they have something along the pathways heading back to the ophthalmic lobes? Do they have something in the vision and the movement of the two eyes and the coordination? All of those questions come up. So the first question is it one eye or is it two eyes?
Terrific question. It's both eyes.
Both eyes. So what you know is he probably hasn't bled into an eye.
So actually, the wife says that he had a stroke last year and they had to remove some blood from his brain. He was just fine, actually, had no problems afterwards, had no permanent damage, quote unquote, no permanent damage, all right? He's just kind of an average 66-year-old male diabetic, kind of heavy set. He was just sitting in the room when I walked in, on the bed when I walked in, and I started talking to him. But I really noticed something very peculiar and important, which is, as I talked with him, he was looking around the room to kind of see where my voice was coming from. Very revealing, actually. So this is his vitals. The blood pressure is 179/98. His heart rate was 63. Respirations were 16. Temps 36.8, and his room air saturation was 100%. I actually took a video of him, and you tell me what you think. This is my actual exam of the gentleman.
I want you to say now when you see my finger wiggling, okay? Here we go, I'm gonna start. Okay.
Yes. Yes.
Okay, we're still doing some more wiggling. Just let me know when you see it.
Yes.
Okay, look straight ahead, look straight ahead.
Yes.
Okay, let's cover the other. Now, can you see my face right here?
Yes.
Okay, now
I'm looking at your nose.
Okay, so once again, just say now or yes when you see my finger wiggling. Okay, here we go.
Yes. Yes.
We're almost done.
Yes.
It cut out that last little bit, which is the his the last little quadrant there. He actually, I had to bring my fingers up way up here in front of him for him to actually see it.
Yes, he has a hemianopsia. In fact, it may be a quadrantanopsia.
Oh, wonderful.
Yes, well, it looks to me like he's got an inferior quadrantanopsia.
So, Dr. Henry, I have diagrams that you can help me teach with visually, because this teaching ocular strokes and visual fields it has to be a visual. You have to have visual tools. So,
Right.
okay.
But Alice, let me tell you, this would get by a lot of people. And the reason is when we do the physical examination, frequently we do things mechanically and never really think about it as to how we complete these things. I'm very pleased that you picked this up, because in a lot of folks, they just would have moved a hand here or there, and people would, and he could be missed by somebody who's not a sophisticated examiner.
Right.
And so it's a good job in picking this up.
Thank you. Well, I'm a old doc. I learned my book knowledge and my academics, I think, very well. And so when I saw this patient, I was excited about my physical finding. Actually, I felt bad for him, but I was like, this is a very unique physical examination. This would be a great case.
Well, a great rule for everyone is anybody who is interesting to the doctor, you don't want to have their disease, because the only thing that's interesting to us is are bad things. You know, the last thing I want to be is interesting to the doctor.
That is 100% true. But when I saw this patient, I was so excited, because it has so much I can teach from here, and I can just go on and on. But this is the CAT scan in the emergency department. And you can tell me to stop.
Stop. Yeah, go ahead.
All right, that's the little 8-second clip of the CT. What are your thoughts on that?
Well, I'm sure this was read by radiology as a lesion. Well, oh,
there it is.
That's very nice.
There it is, right there.
And of course, there it is in the right temporal parietal occipital region, where you notice we predicted that.
Yes.
Before we ever saw the film. And the truth is, the radiology department is for the intellectually destitute. For those people who can actually examine, there's really no question what happened here. That he had this, we knew anatomically where the lesion had to be.
So this is the patient's CT in the emergency department, and then the next day, this is the MRI result.
All right. Well, obviously they see the infarct and in the lobe as we defined. So it looks to me like the patient, everybody is right up to this point in time. He's had a stroke, but could he walk?
Yes, he walked in. Yeah.
Yeah. Well, but does he have normal gait?
That's a good question. I don't recall precisely if he was walking normally.
Henry's 3 laws: hear him talk, watch him walk, look at their eyes, and you can localize almost any disease.
I'm going to have you back on, Dr. Henry, for that. That is a great pearl. that's the case scenario. And as everybody knows, I do try to drill down our learning points on each episode. Otherwise, it would just take forever to go through an episode, right? So
Right.
obviously, for this first learning focus, I'm going to just talk about occipital strokes. So this has always been a little bit of a difficult subject in my career in medical school and in residency. I think most of us know roughly this anatomy, and Dr. Henning, of course, please interrupt me and teach, but just roughly, these are the three general types of central nervous system visual lesions or diseases that can happen. The one on the left here is an optic nerve lesion of all sorts, different kinds of etiologies.
Right.
You would have monocular loss of vision. So
that's the key, Alice, is that this is a monocular visual loss.
Yes.
And here's the rule to anyone listening. Monocular loss is pre-chiasmic till proven otherwise. Because if it's post-chiasmic, you don't lose one eye, you lose a visual field. So instead of a field loss, if it's from the chiasm going forward to the eye, that's monocular visual loss. And one of the best examples of that is if you had an inflammation of the optic nerve. That would give you a monocular visual loss, and in, again, one side, one eye, because it's before you get back to where the chiasm where those fibers divide.
Right. Great. And then you see in the middle diagram there that Dr. Henry is referring to is the chiasm. If you have a lesion at the optic chiasm, then you have bitemporal hemianopsia because of exactly where the lesion sits.
Right. You have crossed and uncrossed fibers.
Right.
So something that's pushing, for example, if you have a tumor or a bleed into the pituitary gland, for example, that could be our middle diagram here, where it's pushing centrally. And so it will get those fibers which come from both sides, which cross, but those that do not cross on the outsides, those will both remain. So that's where you get the bitemporal hemianopsia.
Yeah, that's great. That's great. The one that's on the right, the diagram on the right, is hemianopsia. So this diagram shows a right occipital stroke leading to a left hemianopsia.
Correct.
With visual strokes, it's just like any other motor stroke. If it's crossed. So if you have a right-sided stroke, you have left-sided visual field loss. I just wanted to sort of expand our understanding of what this patient actually had. Okay. So from the examination, you can tell that he had at least a hemianopsia, right? So he had a right-sided intracerebral hemorrhage. That was chronic. That was from last year. And that led to a left-sided hemianopsia, homonymous hemianopsia.
Right.
That was a chronic thing. And then what happened that's new is that he had an acute left occipital stroke, a small one or a quarter one, and that led to a right-sided homonymous quadrantanopsia.
Right.
And that took some time for me to actually figure out, because I just recorded the physical exam without understanding it exactly. I had an idea, but I had to build this in my head to figure out what actually was new and what was not.
Okay.
So my first teaching point really is just to try to understand occipital strokes and how they manifest. What I'll do is I'm going to play this again, and just because I want, now that we've kind of built on the understanding of the anatomy of a stroke, we can take a look at him one more time. It's amazing how far over he couldn't see.
When you see my finger wiggling, okay? Here we go. I'm going to start.
Okay. Yes.
Exactly.
Yes.
Okay, we're still doing some more wiggling. Just let me know when you see it.
Yes.
Okay, look straight ahead. Look straight ahead.
Yes.
Okay. Let's cover the other eye. So once again, just say now or yes when you see my finger wiggling. Okay, here we go. I actually examined him twice because I wasn't sure what I was seeing.
Absolutely.
So he cannot see. I mean, I'm wiggling my finger and he just cannot see until way, way over. Learning focus number 2, it'll be very quick. I had a scribe volunteer because I just want to show and demonstrate how to perform that visual field exam, okay?
Right.
And you'll see how different this one is, how quickly she picks up.
Now. 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 Now.
Okay, cover your left eye.
Now. 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 Now.
So Dr. Henry, thank you so much. Any last teaching points for us? This is always a challenging exam, you know, trying to pick up occipital strokes.
Well, as I mentioned earlier, Alice, if you're a real doctor, if you examine, and I'm from the old school, I'm an examining doctor.
Right.
I should never be surprised by what I see on the CT or the MRA. I should be able to have told them that, and I always do that. If there's a student around, I'll say, "This is what you're going to find," and they're always very amazed. And the truth is, if we take our time and do the examination doesn't lie. It will tell you what you need to know, and the two ought to correlate pretty nicely. Again, Henry's Law of Neurology is in the emergency department. Hear them talk, watch them walk, look at their eyes, and you will learn more about that. Covers 90% of the anatomy of the brain. And if you can do that, remember to do that on each patient, you will be a great emergency doctor. And one of the reasons is one of our jobs in emergency medicine is sending people home.
Right.
If they can't see and they can't walk, you got to do something with them. And so you need to keep that kind of thought in the back of your mind. Nothing gives you more great information for less time than walking. But I'm anatomically based. When I teach the neurological exam, which is the thing I've taught most in my career,
Oh, okay.
We should be able to, in the examination, narrow this things down pretty carefully so that you get the correct test.
Right.
See,
exactly.
Sometimes getting a certain kind of test is not useful.
Right.
And I've certainly seen people with paraspinous abscesses, things like that, where they got a CT and not an MRA, and they didn't find the disease process.
Right.
So our testing, first of all, it's intellectually satisfying to me to get the case right from the exam. But what it really is, it allows you to set the parameters of where I'm going to test and what I'm going to do. So you're not wasting your time on tests that will not answer the question.
That's totally true. And the way I say it is, if you're looking for apples under the orange tree, you're never going to find it.
Right.
You're never going to find it. So you have to look for the apples under the apple tree.
Right, exactly. And that's why examination is so important.
Well, great. Dr. Henry, I am so honored to have you as a guest. I hope that my viewers will appreciate the years of wisdom that you distilled in a very short period of time today. And I would love to do another episode with you on more neurologic emergencies. That would be terrific.
Be fine.
So thanks everybody once again for watching. I really, really, truly appreciate your viewership every month. Now, I hope to see you this coming year, 2020, and one of the conferences I'll be at. Don't hesitate to come and say hi. I don't bite, I promise. Take care. Bye-bye. Bye,
Bye.
Dr. Henry.